All right, last but not least, I would like to introduce our next speaker, Dr. Marleen Meyers, who is a clinical assistant professor in the Department of Medicine, and she is also the director of the Survivorship program here at Perlmutter Cancer Center. Let's welcome Dr. Meyers.
Hi, good evening, everyone. I know that you've probably been sitting. Does anyone need to stand up and stretch, or you're all okay? So we're going to do something a little bit different tonight. I'm going to present sort of a hodgepodge of what I thought were interesting medical oncology issues that were presented this year. So we're going to talk a little bit about adjuvant therapy, hormone therapy, and then some other sort of ancillary things that I hope you'll find interesting. So the updates that we're going to talk about this evening are something called CDK inhibition in early hormone receptor positive breast cancer, extending adjuvant endocrine therapy, scalp cooling to prevent hair loss, abandronate, and does it give adjuvant treatment a boost, and then lastly IBM's Watson computer, which is really fascinating. So let's backtrack because we've heard from my colleagues a lot of really fascinating, wonderful information. So what I'd like to do is just go back to basics for a moment to explain some basic terminology. So HR positive breast cancer means hormone receptor positive breast cancer, meaning that the cancer is stimulated by estrogen. Adjuvant, neoadjuvant versus metastatic. Adjuvant therapy means the cancer is out and we're giving therapy, either chemotherapy or hormone therapy, to kill distant cells. Neoadjuvant means the cancer is not out, we know that the cancer is still there, and we're giving therapy, again, either chemotherapy or hormone therapy to decrease the tumor size. Let me move this over. Is that better? How about that? Yes? Okay. So we're using that to decrease the tumor size with the intent for cure and with the intent to go on to surgery. And metastatic cancer means breast cancer that's not felt in this day and age to be curable, but certainly with breast cancer very treatable. Targeted therapy means therapy that is directed at a particular part of the tumor. So unlike chemotherapy, that's sort of like killing an ant with a hammer, targeted therapy is very specific to different molecules in the tumor. Ki-67 may be a new phrase for some of you, and what that is basically the proliferation index, how quickly cells are grown, and it's given to us in a percentage. And lastly, OS versus DFS. OS means overall survival. DFS means disease-free survival, and they're actually very, very different and important endpoints. So with that, let's start with CDK inhibition in early stage breast cancer. And we know that many breast cancers, in fact most breast cancers, are estrogen receptor positive, and we know from the metastatic setting that when one gets hormone therapy to decrease the tumor burden, at some point this hormone therapy will stop working. So one field of research in recent years has been how can we best stop this resistance? How can we make hormone therapy work better, longer, smoother? And in fact, we have drugs called CDK inhibitors, which stands for cyclin D kinase, that has done that in the metastatic setting. So what we're trying to do is look at this in the early breast cancer setting. So not wait till someone is metastatic, but rather see if using it up front can perhaps affect outcome. And in these trials, it's very important to look at disease-free survival versus overall survival, important to look at toxicity, very important to look at cost, which we'll get to at the end, and ultimately, should everybody get this? So one trial that was presented used in the neoadjuvant setting, and this is a sort of a busy slide, but basically what they did was take postmenopausal women who are estrogen receptor positive, HER2 negative, and give them a drug called abemaciclib, which is a CDK inhibitor, before they ever went to surgery. And this is just, again, a very complex slide, but basically what CDK inhibition is, when a cell grows, either a healthy cell or a cancer cell, a cell goes through various phases from which it's first made to which it divides, and ultimately one cell grows to two cells. And CDK, or cyclin D kinase, is something that stimulates the cell to grow. We know that estrogen receptor positive breast cancers have a lot of this CDK, and we know that by blocking it, you can block the cell from growing. So what we want to do with CDK inhibitor drugs is we want to basically arrest cell growth. So it's basically, we just want to switch. We want to take those cancer cells that are growing and growing, and we just want to put the switch on them. And that's basically all it is. We also know that Ki-67 that I mentioned a bit earlier, which is the proliferation or the growth or how many cells are actively growing when the pathologist looks under the microscope, we know that the Ki-67 can be affected and can be decreased, meaning the cells will be less readily to grow and spread with these inhibitors. So what the study design was, again, the first word, neoadjuvant. So these were people that did not have previous therapy or surgery. Some were given CDK inhibitors, some were given hormone therapy, and some were given, or hormone blocking therapy, particularly with the drug called anastrozole, and some were given both. And the end point of this was not survival. It was not, did people do well? The end point was giving a limited treatment, could that change the Ki-67? Could it make that go down? And in fact, it did. And if you look at the fourth line down, the study met its primary endpoint in that the Ki-67 was a good surrogate for disease-free survival, meaning that in general, in people in whom we could make the Ki-67 go down just by this little manipulation of hormones, that should translate into a better overall survival. So is this something that can be used, and is it something that's suitable for curative therapy for early stage disease? And in Dr. Schnabel's dictum about using a good code, they came up with the PALIS trial, which to me looked like a big stretch to find the word PALIS in this, but it stands for Palbociclib Collaborative Adjuvant Study. And that study is ongoing right now, and what that's doing is using hormone therapy with an aromatase inhibitor plus or minus palbociclib in women who have been treated with surgery and are getting hormone therapy but are at higher risk. So what's a higher risk? A larger tumor, multiple lymph nodes, a high Ki-67. So that's in the process right now, and we're waiting on that to be completed, which will take a while, and then ultimately results. This is just a study design. You can see that people were randomized to either getting aromatase inhibitors, to getting the CDK inhibitor, or a combination. And again, the endpoint was not survival. The endpoint was simply, could we make the growth of the tumor decreased? And indeed, we were able to do that. This, however, does not come without a cost, and whenever we look at trials and we look at new treatments, the cost, I don't mean only the monetary cost, but the cost in terms of side effects has to be considered. And if you look at grade 1 alone, which is the most mild of symptoms, you can see that 36% of people had constipation, a significant percentage had nausea, fatigue, abdominal pain, and this is something that rarely happens with the aromatase inhibitors alone. But in summary, basically this did meet its endpoint. The side effects were tolerable, and the answer right now, or the question I should say, is this going to be helpful? If we use this sooner rather than later, can we further decrease the number of women who will recur with breast cancer down the line? So moving on to the next topic, which is extending adjuvant hormone therapy. Does this make sense, and for whom? And this really comes at the heels of the tamoxifen data, and as many of you know, tamoxifen is a hormone therapy used mostly in premenopausal women, but can be used in postmenopausal women. We know that using tamoxifen for 10 years works a little bit better, only by a few percentage points, but nonetheless a little bit better. And we know in general that in postmenopausal women, aromatase inhibitors work a little bit better. So what this study did was, actually the main study that was done was the NSABP B42, but there were other trials that were done in Europe, as well as earlier trials that were reported out previously. But what they did was look at women who had gotten tamoxifen tamoxifen plus an aromatase inhibitor or an aromatase inhibitor and essentially add on another 5 years of an aromatase inhibitor. So those are drugs like letrozole, anastrozole, exemestane. And what they did not find was a significant benefit in either overall survival or disease-free survival. So let's look a little closer at the data. So what we knew before these trials was that when you are estrogen receptor positive, the paradox of that is that ER-positive breast cancers are more favorable. But when people recur, meaning distant disease with estrogen receptor positive breast cancers, there is a significantly high recurrence in year 5 to 10 as opposed to year 1 to 5. So because of that, there really is this impetus to see, does extending hormone therapy make a difference in that? Will it decrease survival? So as I mentioned, we do know that greater than 50% of disease will relapse after the first 5 years. And that's why this idea of extending hormone therapy is appealing. We know that aromatase inhibitors are a little bit better than tamoxifen. We know that sequencing tamoxifen and an aromatase inhibitor is an alternative to 5 years of an aromatase inhibitor. And we also know that tamoxifen, 10 years versus 5 years, is beneficial. So, and we also know that adding an aromatase inhibitor after 5 years of tamoxifen is beneficial as well. So, is adding an aromatase inhibitor after an aromatase inhibitor beneficial? So that didn't turn out to be so beneficial, and in fact, as of now, the data is not at all very clear. What the NSABP data showed is that there was neither a disease-free or an overall survival if one added an additional 5 years of an aromatase inhibitor to previous aromatase inhibitor. But I will say that the data is a little bit muddied by the fact that there was a compilation of people in the first 5 years, meaning that they got a whole host of combinations. Some got tamoxifen, some got 2 years of tamoxifen and 3 years of an aromatase inhibitor, some got an aromatase inhibitor. So there were a whole host of things. And then also, as was previously mentioned by Dr. Schnabel, the compliance is very, very difficult to know for sure because many people don't want to really tell their physician that they're not exactly taking this regularly because it will be disappointing. They're afraid they'll get yelled at, whatever the story. But nonetheless, the compliance we know is not good, but we also know that we don't know what the compliance is. So again, this is the schema. Anyone who has had previous hormone therapies was randomized to letrozole for 5 years or placebo. And you can see from previous slides, we're very used to these graphs now. You can see how very close those lines are. So no significant difference in disease-free survival. And by the way, disease-free survival means the time from when you get the cancer till the time the cancer comes back. That's all it means, and it doesn't necessarily mean the same as overall survival. So the summary is this addition of an aromatase inhibitor for an additional 5 years did not meet statistical significance. But what in some studies, not in these in particular, this B42 actually did not show any significant increase in terms of toxicity, but let's look at a few other studies. So the conclusion was basically that while there may be a benefit to some people, this trial did not show a benefit to extended therapy. Therefore, the recommendations of 5 years of an aromatase inhibitor are the current recommendations with consideration to go longer, but on an individual basis. The MA17, just to mention, that was a study that was reported out at ASCO this year, so that was back in June. And to show you some of the issues involved is on the MA17 there in fact was an increased risk of bone fracture, there was an increased risk of bone pain, and there was an increased risk of new osteoporosis on people with prolonged aromatase inhibitor therapy. So who might we consider this with? It seems that there is a little bit of a trend towards people who have required chemotherapy, so meaning more aggressive tumors. There may be a bit of a trend towards the benefit of extended therapy, perhaps in people who have node-positive tumors, larger tumors, prior tamoxifen, but the prior tamoxifen sort of goes hand in hand with the knowledge that we know that the aromatase inhibitors work better than tamoxifen alone, so simply giving the AI may be beneficial. Interestingly, the genomic risk profiles is something that we're starting to look more and more into. So things like the oncotype or the mammoprint, things that give us a little bit better idea as to the aggressiveness in the tumor may influence who we treat longer and who we don't. But crucially, treatment has to be individualized. One of the very important topics, God bless, that I think is really on the forefront is scalp cooling. And needless to say, anyone who has experienced a medical oncologist sitting opposite you telling you that you're going to lose your hair, you sort of blank out everything else. So certainly maintaining hair during chemotherapy is very crucial if it can be done. And there in recent years has been a very big push towards scalp cooling or cold caps or whatever the current vernacular is. So this is a very simple trial, and while it's a very basic trial, I think some interesting things came out of it. So the scalp cooling trial, this is very clever, scalp cooling alopecia prevention trial, Scalp, which is, I think, terrific, was done at the Baylor College of Medicine. And again, very simple design. We know that chemotherapy is associated with alopecia or hair loss, and we know that it's a very stressful side effect. Many countries do routinely use scalp cooling and pay for scalp cooling. The United States does not. The first device was approved in 2015, and there actually have never been randomized trials up until this one using it. So a couple of interesting things came out. This is, first of all, what the device looks like. It sort of looks like the old-fashioned types of hair dryers. The difference is the cap sits on your head. It is occlusive, meaning it should stick to every single millimeter of your scalp. If it does not, that 1 millimeter it doesn't stick to, you will lose your hair. So it has to be completely occlusive. And basically this cool liquid runs through constantly. You have to come before chemo and you have to remain after chemo with this on your head. So again, very simple design. People enrolled, they were randomized, you either got it or you didn't get it, and people were studied for hair loss, quality of life, and device safety. So as to say, the device is very safe. So this goes without saying. On the left, you can see people who got the cooling device. In about 50% of people, it was a success. In about 50%, it was a failure. And on the right was non-cooling, so it was 100% failure. Again, not surprising, sort of quite intuitive. But let's look at the adverse effects. Again, not terrible. The older cooling caps, many people used to complain about really freezing and shivering and having to sit with blankets, and it was very cumbersome. This is much less so. And you can see really the main side effect is headache, really nothing else of significance. Most people reported this as reasonably comfortable. But look at the bottom blue line. The quality of life assessments showed no difference. So whether you lost your hair or you didn't lose your hair, it didn't seem to make a difference in terms of how people described their quality of life. And very importantly, when one looked at the toxicity, meaning how likely were you to lose your hair versus not losing your hair, when you look at the grade toxicity, if you look at grade 0, it means people reported no hair loss. If you look at grade 1, which is a low toxicity, grade 1 was actually 50% hair loss. And what happened in this trial was, and this is just to show you the difference between chemotherapies, on the left are the taxanes, so drugs like Taxol or Taxotere, which worked reasonably well with this cap. On the right were the anthracyclines, so drugs like adriamycin, which did not work particularly well. But very importantly, the statistics were about 50% of people lost 50% of their hair, which means that 50% of the people who sat with this cooling cap for every chemo treatment still lost at least 50% of their hair. So what do we know? We know that it is effective in some people. We are looking for FDA clearance, but we need further studies in terms of, does it affect overall survival? Does it affect anything that may in fact hamper a person's life? And why is that important? In the early days of cool caps or cold caps, there was a thought that if you have the cold cap on, the way it works is by constricting blood vessels so the chemo doesn't get to your skin. And we know that many cancers, specifically breast, lung, ovarian cancer, can metastasize to the skin, and your scalp is skin. So there has always been a concern, unproven, that that might be an issue. So certainly more studies are needed. More quality of life has to be considered, and also payment issues have to be considered, because currently it is not reimbursed, it is very expensive. Bisphosphonates to boost survival. So bisphosphonates are the drugs that everybody doesn't want to take, because everyone's convinced that they're going to have a spontaneous fracture and have their jaw right out of their mouth. So why is this important? It's important because for many, many years, bisphosphonates, which are the drugs like Boniva, Fosamax, Actinol, have always been tied with the possibility in postmenopausal women that breast cancer risk may be reduced in terms of risk of recurrence. And this is particularly true in postmenopausal estrogen receptor positive breast cancer. So the main trial that was done in this country, and there were several trials done other places, but the Team 2B trial, which did look at 3 years of a bisphosphonate as well as hormone therapy, did not show any significant advantage. There was a trend towards disease-free survival, which may or may not in the long run make any difference. But the main criticism of this study was that the analysis was done prematurely. And remember what we spoke about before, that if you're estrogen receptor positive and you're going to recur, there's at least a 50% chance of recurring 5 years and beyond. This trial did not look to the 5 years and beyond. So we don't really have great data about that. Again, this is the trial design. It was, and in addition to the trial design, there was also a meta-analysis which looked at 17,000 previous patients, and all of this failed to show a significant overall survival or even a significant disease-free survival. Again, those same curves that are right on top of each other. Time to first bone metastases, which is what we're also trying to prevent, metastases in general, but also specifically bone metastases, and again, no significant difference. Safety and toxicity. So to put some things to rest, I think this is very helpful in that the safety and toxicity profile was very acceptable. There were some gastrointestinal symptoms, but if you look down towards the end, only 4 patients developed osteonecrosis of the jaw. And that's the real fear, in this setting of whether you're taking these drugs for bone density, whether you're taking it in the adjuvant setting. The actual risk of osteonecrosis of the jaw is very, very small. So the conclusions was that there was a trend towards disease-free survival, but only at 3 years, which is not nearly enough time. There were less bone metastases at 3 years, again, not nearly enough time. It was safe. The side effects were certainly tolerable, but this is not enough to say anything meaningful about using bisphosphonates in the adjuvant setting. So one of the most interesting talks I heard, which if you don't like your doctor, this is a really great talk to hear, is about IBM Watson, which you may recall was the Watson computer that beat the best Jeopardy candidates in 2011. So they sort of wanted to see, this group from India wanted to see if they could beat the best oncologists in the world. And in fact, it did a fairly decent job, and the way this computer system works is the information is fed into the computer system. It was actually fed by oncologists at Sloan Kettering, but it was tried in India, in a major hospital in India. Now, the caveat about this is that the practice of oncologists in India is not according to what we would consider NCI guidelines. And that's because sometimes there's no money for best drugs, sometimes there's you can't get people to the hospital, so things are a little bit skewed. But the very interesting thing was, there was a lot of concordance between Watson and the doctors in India. So if you look at line 2, the recommendations were concordant in 79% of the time when there was no metastatic disease, but only 46% of the time in metastatic cases. And that also is partly because in India they tend to use more than one drug at a time because they don't know whether people will be able to come back. So they sort of throw the book at you, so to speak, whereas here we use our drugs a little bit more judiciously. In triple-negative breast cancer, there was about 68% concordance, and in HER2 positive, HER2 negative, only about 35%. So as the director of this study said, that it can't replace human clinical judgment and the essential patient-doctor relationship will still hold, but I'm not so sure about that. And if you look at the outcomes of the study, and if you look at the study design, it really is based on the fact that we are getting so much data every year, and the important part of this slide is really the bottom, that medical information is doubling every 5 years. There's 75 new clinical trials that start every day in the United States alone. And peer-reviewed articles, there are 2.5 million peer-reviewed articles per year. So Dr. Schnabel can remember that. I can't. And it's really, this is really a very interesting, not if we use it as a helper, as sort of a tumor board kind of thing. Of course, it doesn't replace the care that we give our patients, but it certainly is nice to have a second checklist at least to run things by, Watson when there's a difficult decision to make. So just to go through a couple of things to sum up. So looking ahead, what are some of the key topics? The key topics were to avoid overtreatment, de-escalation of therapy, consider the host, meaning consider the patient and other comorbidities, consider the cost, new ways to test new therapies, primarily in the neoadjuvant setting. We need to individualize care, and we need more physical activity and nutrition. We spoke a little bit about cost, and to give you the idea, if we look at palbociclib, which is the third one, which is one of the CDK inhibitors, the cost of that drug is $120,000 a year. Trastuzumab, Herceptin, is $76,000 a year, and we've added on the third from the bottom, pertuzumab, which is $102,000 a year. So the cost of the drugs, every time we go to use one of those, you're looking at $100,000 to $200,000 a year for the drug costs, never mind the blood tests, the visits, the transportation, et cetera, et cetera. So we do have to come to understand how important these drugs are. Are they worth it? Are they worth the toxicity? Do they work well enough to spend this money on the drugs? And lastly, what's happening over the future? There's a lot of work on therapeutic resistance, a lot of work on overtreatment, and a big nut to crack is really health equity, because there's a major problem in this country in the haves and the have-nots. And that is not going to be an easy problem to solve. People in big cities do have access. People in small cities, rural area, have no or little access. And this is one of the great challenges of oncology. So thank you for your attention and for sitting through this, and see you next year.